For those of you who don't know me, my name's Andrew Tagg, and for the last 9.5 years, I've edited 1,253 blog posts for the website. That has been a hard task, but it's made so much easier by clinicians like these three on the stage who have a look at the papers, have a look at the evidence, and turn it into understandable, plain English, as opposed to medicalese. Over the last 5 years, headed by, first of all, Henry Goldstein and now Vicky Curry, every month we produce a compendium of 5 papers to look at. Now, these are not the 5 most important papers in the world of PEM, because otherwise we'd still be talking about COVID. But these are the 5 most interesting papers to them. Things that may change their practice, things that make them question what they do every day. And so, over the course of the next hour and a half, our speaker is going to ask you to question your practice a little bit. First off, dabbling into the world of pediatric emergency medicine, Nandini Choudhury from Logan.
Thanks for the introduction. Now, as Andrew said, as an emergency physician, I'm going to try and focus on talks on papers that I feel have changed my practice, or at least made me question how I changed my practice. And I'm going to start with what I think is probably one of the most mind-blowing papers of the last year for me. Now, it's not so much a research paper per se, but it's the new guidelines that's been released by the American Academy of Pediatrics with regards to the management of well febrile infants aged 8 to 60 days. Now, chances are most of you here have probably already heard of this paper, as fever is undoubtedly one of the most common presentations we see in the emergency department, approximately 20% of our presentations. And it wasn't so long ago, as Jason Ackwood mentioned, where we were doing full septic workups on all infants who presented under the age of 3 months with a fever, because these children can look really, really well, but actually be septic, or so we were taught. Now, in these new guidelines, what I think is important to remember is they have quite specific inclusion and exclusion criteria, and it refers to well febrile infants that were term and didn't have a complicated perinatal history. Now, what's happened is a panel of experts have looked at over 150 papers, and they generated about 21 key action statements. Now, don't worry, I'm not going to go through all of them. But essentially, they came up with these 3 algorithms. Again, I'm not going to go through them in detail, but essentially what they've done is they've further divided it into 3 main groups: 8 to 21 days of age, 22 to 28, and 29 to 60. Now, according to these new algorithms, provided none of these red flags are present, the child examines well, and you've done some screening tests and they're normal, and the child is over 21 days of age, you don't have to stick a needle in their back. However, it is also important, I think, to remember that these new guidelines do use urine and blood tests as a screening tool, and they do use specific inflammatory markers as a screening tool, specifically procalcitonin, which we know is much more specific for bacterial infections, but at the same time is not readily available in most centers. And that is why these guidelines also talk about, if you don't have procalcitonin, the use of absolute neutrophil count and CRP and a temperature of over 38.5 as being a marker of potential bacterial infection, and when a full septic workup should be considered. What I do also like about these guidelines is they do have mention about herpes simplex virus, which I think is sometimes often forgotten. And they do mention that if you are concerned about herpes simplex virus based on the history or examination, then this is when you need to think about whether you need to do a lumbar puncture. So while I think the Australia and UK guidelines and New Zealand guidelines to extent haven't quite yet formally changed to reflect what our American counterparts are doing, what these guidelines do tell us is that perhaps we need to rethink the need for potentially unnecessary invasive tests in children in this age group. And I suspect that in the near future, we might see change in our actual guidelines and how we practice in this age group. But that being said, as with most things, there's always a caveat, and a guideline is always a guide and does not replace clinician gestalt. Now, this wouldn't be a talk about studies in pediatric emergency medicine if I didn't have at least one respiratory paper in it, and for that reason, I have two. So let's talk about CAPIT. So this was a UK study done in about 29 hospitals in the UK and Ireland over a 26-month period. Now, this was a randomized, blinded, placebo-controlled, multi-center, non-inferiority trial. Geez, that is a mouthful, isn't it? So essentially, what this study was looking at is the management of uncomplicated pneumonias in kids. So they included kids that were over 6 months of age, weighing between 6 to 24 kilograms, and had the diagnosis of pneumonia and were discharged from hospital within 48 hours. Now, how did they diagnose pneumonia? Well, they used the British Thoracic Society guidelines, which essentially included three things: a reported cough in the preceding 96 hours, a reported fever in the last 48 hours, and signs of labored or difficulty breathing or focal chest signs. Now, I think it's great that they didn't include chest x-ray as a means of diagnosing pneumonia, because we know that chest x-ray can lag behind clinical findings. But what I do think is important to remember is that using these criteria, there is probably a subset of children that probably had a viral infection, a viral lower respiratory tract infection, and were going to get better regardless of whether or not they were going to be given antibiotics. That being said, I still think it's a pretty robust study. Now, what was the study wanting to look at? Well, they wanted to look at two main things. They wanted to look at low dose versus high dose amoxicillin, so 30 to 50 milligrams versus 70 to 90 milligrams per kilogram. And they also wanted to look at the duration of antibiotics. So they looked at a 3-day course versus a 7-day course of antibiotics. The primary outcome they looked at was retreatment with antibiotics within 28 days. And the secondary outcomes they looked at were things like severity, duration, side effect, as well as adherence to treatment. Now, what the study found was that there was no significant difference between the groups. So a low dose was just as good as a high dose, and a shorter course of antibiotics was just as good as a longer dose. Now, what they did find in terms of the secondary outcomes was that the duration of cough was slightly longer in the group that had the 3-day course of antibiotics. So it was 12 days compared to 10 days in the 7-day course of antibiotic group. What I also do like is the fact that they used a BD dosing of amoxicillin as opposed to the traditional TDS dosing. And as a parent of a toddler, I'm all up for that. And I think it probably goes without saying that if you have an antibiotic that you need to give a child twice a day, you're probably going to be more successful than trying to give it to them 3 times a day. Now, we all know what the marker of a good study is. It's one that has a good acronym. And this one is hot off the press. I think definitely takes the cake. It's the FORCE trial. Now, this was another UK study done between January 2019 and July 2020 in 23 emergency departments. This was a multi-centered, randomized, non-blinded equivalence trial that included about 965 children aged between 4 to 15 years of age. These children had isolated distal radius torus or buccal fractures that were confirmed on X-ray. So they wanted to look at the management of these common fractures that we see in the emergency and basically randomize them to either rigid immobilization versus soft bandage. Now, in the rigid immobilization group, these kids, about 95% of them had a removable splint, and the remainder 5% had plaster of Paris versus the soft bandage group. They obviously had specific exclusion criteria, and if you were a delayed presentation, you were excluded from the study, as well as if you had any cortical disruption on the X-ray, because that doesn't quite fit with a buccal fracture. And if follow-up was not possible, because the follow-up was actually done via phone call, so things like language barriers meant you were excluded. So what they looked at in terms of the primary outcome was they looked at pain on day 3. They also looked at pain scores on day 1, day 7, week 3, and week 6. In terms of the secondary outcome, they looked at parent-reported functional outcome, analgesia use, days of absence from school, as well as treatment satisfaction. And what they found was that there was no difference between the groups. So soft bandage was just as good as rigid immobilization in the management of buccal fractures. In terms of the secondary outcomes, they did find that analgesia use on day 1 was slightly higher in the soft bandage group, and it was only marginally higher, 83% versus 78%. Now, what I also found interesting from this study was it was actually going to be a study looking at rigid immobilization versus no treatment. However, parents in the focus group didn't like not having an intervention, so the authors included soft bandage and so nothing like a good placebo effect. Now, for my second respiratory paper, as a pediatric emergency physician, naturally, I had to include high flow in it because don't we all love a little bit of high flow? So this one is also known as the first ABC step-up high flow versus CPAP, no prizes for this acronym, which basically was a randomized non-inferiority trial that included 600 patients aging from 0 to 15 with any acute respiratory illness that needed respiratory support, so needed a PICU or HDU admissions. And they were randomized to either CPAP or high flow, not that one, CPAP or high flow. So 2 liters per kilo of high flow versus CPAP 78 centimeters of water. Now, out of the 600 patients, the median age was actually 9 months, and about 50% of the patients were actually diagnosed with bronchiolitis. So what they looked at was, so the primary outcome, and I love how it's framed, was time from randomization to liberation of respiratory support, because it sounds like these kids are being held hostage in PICU. Secondary outcomes they looked at were things like mortality, intubation at 48 hours, length of stay in both PICU as well as in hospital, need for sedation, adverse events, and parental stress. So what they found was that this was the time that high flow versus CPAP spent with any acute respiratory illness, which when they did the math meant that it met the criteria for high flow to be considered non-inferior to CPAP. Now, in terms of the secondary outcomes, high flow did a little bit better. So the PICU stay was actually shorter, as well as the hospital stay was shorter in the high flow group. So 5 days in PICU versus 7.4, and in hospital it was 13.8 versus 19.5. The high flow group, not surprisingly, required less sedation and reported less adverse events. Now, in terms of treatment failure, which was defined as if there was switching or escalation of care, the CPAP group reported a higher number of treatment failure, and the main reason for treatment failure in the CPAP group was patient discomfort. So I guess it appears high flow wins again. But you can't talk about the step-up trial without talking about its sister study, the step-down trial, which was another trial that was published earlier this year that actually looked at patients that were extubated from PICU and were put onto either high flow or CPAP. And they looked at how long it took for them to be weaned off non-invasive or liberated. And in that study, they found that it was actually 50.5 versus 42.9 hours, which meant high flow was inferior to CPAP. Now, obviously, there's always going to be some flaws to the study, and I think the biggest flaw with this is you can't blind something like this, so there's potential bias. The switching from high flow to CPAP and vice versa might have potentially been affected by various things from clinician experience to clinician preference. I also think that it did include quite a heterogeneous group of patients from aging 0 to 15 with a variety of respiratory illnesses. And arguably, there may be some respiratory illnesses that might benefit from high flow or CPAP, and the study didn't look into that. Now, last but not least, I've got an Australian study. Now, this was a prospective randomized controlled trial that was done in a tertiary pediatric emergency department in Perth, looking at the management of another common fracture we see in the emergency department, the toddler's fractures. And they wanted to compare using a above-knee plaster of Paris, which is what we've been traditionally taught to do, versus using a cam boot or a moon boot. Now, obviously, this was a single-center study, so it was a much smaller study and only had 87 patients in it. Now, what they found from this study was that the authors hypothesized that if you did put children in a moon boot, it'd be much easier to care for them when they're daily ADLs. And guess what? They were right. So how did they assess this primary outcome? They had what they called a comfort and care questionnaire for the parent to assess the ease of personal care. And they looked at some secondary outcomes such as weight-bearing status, complication of fractures, as well as pressure injuries. And what they found was, obviously at the 6 to 8 week marks, parents who were in the moon boot had much higher levels of satisfaction because it was a lot easier to care for their children in a moon boot. Now, there was, interestingly, also no difference in pain scores between both groups, and not surprisingly, patients in the moon boot group reported that there was initial weight bearing was a lot quicker than in the group where they had a plaster of Paris with their legs in this position. Now, in terms of weight bearing status, there was 2 patients in the plaster of Paris group that at the 6 to 8 week mark reported persistent partial weight bearing. And when these patients were brought in for an in-person review, they didn't notice any significant difference. In terms of adverse events, there was one adverse event, but I'm not sure I would call it an adverse event. It was in the moon boot group where a child on day 7, there was noted to be widening of the fracture. However, on retrospective review of that child's initial x-ray, it was thought that there was some minimal displacement of the tibial fracture, which should have excluded them from the study. There was another patient in the moon boot group that reported a fall while being in the moon boot, and despite the fact that the second x-ray didn't actually show a fracture, due to ongoing pain, this child was then swapped over and put in a above-knee plaster of Paris. What I also thought was really, really interesting was the pressure injuries was actually similar across both groups. I would have thought that if you had a moon boot and you had something that was removable, you'd have less pressure injuries, but that was not the case. So I think this is a great study. We probably need some bigger multi-center studies to further, acknowledge the results from this study, but I think what it does tell us is think about putting that toddler fracture in a moon boot because you're going to save the parents a world of pain. Thank you.
And before we go over to the audience, I'd like to ask Nandini, have any of these papers actually changed what you do at work?
Yes. I think, so talking about the orthopedic papers, it's definitely made me think a bit more about, right, we are doing the right things with not jumping and going, right, plaster of Paris. Has it changed formally with regards to how we, our current practice at our hospital? I think it's something that I would like to have that discussion with the orthopedic team because often they're the ones following up on these patients, but it definitely has. The other ones, I think the big one that has changed my practice probably, I would say, is the guidelines with the febrile infants, because it's really made me think harder, does this child need that lumbar puncture? And it's, I think Scott's going to talk a bit more about it, but I think it does also open up the discussion of we should really be talking to the parents and having that shared decision-making model with the parents. But I would say, and speaking to a colleague who actually trained in the States and did all his training there, I think one thing worth remembering is that our healthcare system is different, very different from how it is practiced in the States. One big difference is in States, the way the model is, it's a lot easier. If you get discharged from the emergency department, it's a lot easier for you to be followed up. Your primary care physician for your child is usually your pediatrician, as opposed to the Australian system where that's not always possible. So I think it's definitely made me think about doing that invasive test, but opening the discussion with everyone involved.
Thanks, Nandini. Do I have any other questions in the audience? No? Well, one study I would love to see Dan Perry do is, does the color of the bandage make a difference? Is it maroon, so they're going to get better faster, or something else? Maybe we'll suggest that to him.
You won't be able to do that in the NHS because we can only afford one
It's all
type of
crap.
bandage.
It's all, sorry, crap. Okay. Okay. Thank you very much, Nandini.